Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is diagnosis of stress urinary incontinence. How we define it is there is an involuntary leakage of urine, any amount of urine. Whenever there is an involuntary passage of urine, that is incontinence. But in stress urinary incontinence, it is usually in small amount, which is associated with increased abdominal pressure or straining, activities which lead to increased abdominal pressure or straining, such as coughing, sneezing, or sometimes in severe cases even laughing also. And definition also includes that this passage of urine which is bothersome for the woman. So these are the three components of the definition of stress urinary incontinence. There is incontinence with increased abdominal pressure and it is bothersome for the woman. On the other hand, a close differential diagnosis of stress urinary incontinence is urgency incontinence, where there is an urgency. Desire to pass urine immediately is urgency. So this urgency precedes or accompanies leakage. That is how by history only we can differentiate between these two, that is stress and urinary urgency incontinence. In urgency incontinence, usually the urine which is passed is in large amount as compared to SUI or stress urinary incontinence, and urgency incontinence is usually because of overactive bladder, or sometimes it can get aggravated by urinary tract infection. Mixed incontinence is when there is a simultaneous presence of both, that is incontinence with increased abdominal pressure, SUI, as well as it is associated with sensation of urgency. What is occult SUI is SUI in pelvic organ prolapse, which becomes overt after reduction of prolapse or surgery of prolapse. Now, urodynamic studies. What are the urodynamic studies? There are two types of, that is in detail we want to know bladder function as well as bladder capacity, that and urethral function, urethral capacity. That is in short called as urodynamic studies. There are two types of these urodynamic studies. One is simple cystometry and other is complex multi-channel urodynamic study. In simple cystometry, only bladder pressure is measured by a cystometer, whereas with complex multi-channel urodynamic study, bladder pressure, urethral pressure, intra-abdominal pressure, all these are measured. Abdominal pressure is measured with the help of a rectal or vaginal catheter or probe, and all these are measured by using transducers. Now, the reason why we have seen these types of urodynamic studies are there is a separate definition of stress urinary incontinence when we do the diagnosis on the basis of urodynamic study. So, urodynamic study definition of stress urinary incontinence, it is called as genuine stress urinary incontinence. So, here what is happening is there is involuntary loss of urine with increased intra-abdominal pressure with absence of detrusal muscle contractions. So this can only be ascertained whether detrusal muscles are contracting or remaining relaxed at the time of incontinence only with the help of urodynamic study, and that is why genuine stress urinary incontinence is a diagnosis of complex urodynamic study. Clinically, we can't diagnose a case as a genuine stress urinary incontinence. In short, here we are confirming that there is no detrusal activity or overactive bladder or urgency incontinence, and that is why it is called as a genuine stress urinary incontinence, which can only be diagnosed by doing urodynamic studies. Now, by urodynamic studies, whenever there is a detrusor muscle overactivity or overactive bladder, OAB is overactive bladder. So this is detrusal muscle overactivity or overactive bladder is a type of urgency incontinence, which is again diagnosed only by doing urodynamic study. Mixed incontinence is when there is a leakage with both. When we are doing urodynamic study and there is a passage of urine with involuntary escape of the urine with raised intra-abdominal pressure as well as with detrusor contraction. So what we need to remember is the clinical definition of stress urinary incontinence is as the patient gives history of involuntary passage of urine with raised intra-abdominal pressure and which is bothering her. But juvenile stress urinary incontinence, if you are asked the question, what is juvenile stress urinary incontinence? Your answer should be, it is the stress urinary incontinence which is diagnosed by doing urodynamic study where we document that there is a incontinence with raised intra-abdominal pressure, but there is no associated detrusor muscle contraction. That should be the correct answer. In the differential diagnosis of stress urinary incontinence, closest is urgency incontinence, where there is a detrusor muscle overactivity, or it is also called as overactive bladder. Mixed incontinence, where there is a combination of stress and urgency incontinence, and by careful history taking, we can ascertain whether one cause is dominant on the other. That means mixed incontinence with SUI dominance or mixed incontinence with urgency incontinence dominance. Or there can be a chronic urinary retention in a patient if there is some dysfunction, bladder dysfunction, voiding abnormality is there, or there is any obstruction to the urine flow. Then what patient can present with is a chronic urinary retention, which is associated with incontinence. With chronic urinary retention also, there is involuntary passage of urine. Coming to the most important part is pathophysiology of stress urinary incontinence, and so many times as gynecologists we can diagnose SUI easily by history and examination, but whenever we think about pathophysiology sometimes we find it a little bit difficult, and that is why I have tried to simplify it as much as possible. So in the pathophysiology, the first thing about SUI is it is complex and not fully understood. And that is why whenever we talk about pathophysiology, usually we talk about theories of pathophysiology of SUI because there is no definite confirmation. What exactly is the underlying cause? There are three components in the pathophysiology. We can divide it diagrammatically also, and you can remember also. First component is urethral component, where there is a problem in urethra itself, where there is a reduction in maximum urethral closure plate pressure, or urethra itself is remaining slightly open even during rest also. And because of this weaker urethra only, there can be incontinence. Second is urethral hypermobility with the reduction in uretrovaginal support, where it is associated with descent of the urethra, more of a urethral mobility because of the weakening of surrounding supports to the urethra. That can be the problem, can be. This is the second pathophysiology. Here, there can be underlying difficulty or the underlying problem. And third is whatever increases the intra-abdominal pressure. Increase intra-abdominal pressure on the bladder during straining, such as patient has chronic cough or has severe constipation, all these or obesity, all these will increase the intra-abdominal pressure increase will be more, and that will be the pressure, more pressure on the bladder during straining. So combination of these three usually is the main main three factors in the pathophysiology of SUI. Remember, problem in urethra, problem in the surrounding tissue, and increase pressure, bladder pressure with the increase intra-abdominal pressure. So this diagram, if you draw, if you practice, you will be able to categorize the pathophysiology to make it simplified for the stress urinary incontinence. So various theories are there. there is these theories. If you get, now suppose you are asked about the pathophysiology in short, then the previous slide is sufficient. Where you can say problem can be in the urethra itself or in the surrounding support of the urethra, or there can be more of a exaggeration of the abdominal pressure. But if you get a theory question on pathophysiology of SUI, then you need to give in details about various these theories which I am going to explain. First is a urethral position theory, which was discussed by Kelly and Honis long back, which according to which there is a urethral position which has gone down below the normal level, which is leading to intra-abdominal pressure not getting transmitted to the urethra. So with raised intra-abdominal pressure, urethra is not getting closed but remains patent, and that leads to incontinence is this theory. Second is intrinsic sphincter deficiency theory, which was IST, which is also a very favorite theory in the pathophysiology, which was introduced by McQuarrie. By this, there is a poor periurethral support tissue, which leads to the urethra remaining patent, and that is why it remains urethrovesical junction or bladder neck itself is weak, and that is the reason why there is a involuntary escape of the urine with every act of increased intra-abdominal pressure is this intrinsic sphincter deficiency ISD theory. Third is hammock theory, which was introduced by D. Lancey, according to which there is a laxity in the pubococcygeus back plate. So this pubococcygeus part of the levatrina muscle or pelvic floor, it provides hammock, and if there is a laxity of this, then that leads to urethra remaining becoming patent with raised intra-abdominal pressure. Integral theory was by Petros and Almstein, and according to that, there is a weakening of pubourethral ligaments that leads to the urethra becoming lax, and that leads to the incontinence with raised intra-abdominal pressure. Now, what we need to understand is, in a given patient, there can be combination of all these factors. Urethral position might be slightly lower or abnormal. There can be associated sphincter deficiency with the pubococcygeus becoming lax, and the ligaments also are getting weakened. And all these in combination can lead to SUI in a given patient, rather than one patient having only one underlying pathophysiology. So this is most important. That is why I have made it bold that in a given patient, we can have combination of all these four factors or underlying underlying what we can say the underlying pathophysiology problems in a given patient. Every SUI is now in with a modern research. What we have come to understand is every SUI is now considered a combination of intrinsic sphincter deficiency and urethral hypermobility. So usually in a given patient, there is a presence of both. That sphincter deficiency is there, as well as there is a urethral hypermobility. That means urethral position has become abnormal, either because of this hammock theory, lax pubococcygeus backplate, or and because of the weak pubourethral ligaments. So what is this hammock theory of D. Lancey? This is like a hammock, and the urethra is resting on a hammock which is formed by endopelvic fascia and anterior vaginal wall. So till the time anterior vaginal wall and endopelvic fascia are strong and in normal position, with that there is even the hammock has got the strings by the arcus tendinous fascia pelvis, which is getting attached laterally to the vagina, as well as to the levatrina muscles supporting the levatra or supporting the vaginal wall, anterior vaginal wall together. So these are like strings. This arcus tendinous fascia pelvis and levatrina muscles are strings of this hammock, and hammock itself is formed by endopelvic fascia and anterior vaginal wall. So what happens with increased abdominal pressure is there is this pressure compresses the urethra against this support formed by anterior vaginal wall and endopelvic fascia. And because of this compression, the urethra remains closed and the continence is maintained in spite of increased intra-abdominal pressure. What is happening is whenever there is a weakening of the support, weakening of either anterior vaginal wall support or endopelvic fascia weakening, this compression of the urethra against the support fails to take place, and with the weakened supports, incontinence takes place with the increase in abdominal pressure. Now, this terminology you will see in many textbooks or whatever articles you will read about SUI is intrinsic sphincter deficiency. But remember that this terminology itself is confusing, and there are 4 definitions of this terminology given in Thiele's operative gynecology. One is some authors think that this ISD is a type of severe SUI. So any patient who has severe SUI is thought to be having intrinsic sphincter deficiency. Second definition is presence of SUI with no urethral hypermobility, or we will see classification later on in which it is said to be type 3 of SUI, where urethral hypermobility is absent, urethral position is normal, but there is a presence of SUI. If we do third definition is on urethroscopy, if you can see an open bladder neck at rest, then it is diagnosed or defined as a case of intrinsic sphincter deficiency. And fourth definition is there is lower maximal urethral closure pressure whenever it is less than 20 centimeters of water, or there is a lowering of leak point pressure, which is if it is less than 60 centimeters of water. So all this definition is based on complex multi-channel urodynamic study, and some authors believe that we need to have these criteria to be fulfilled to label a case as having intrinsic sphincter deficiency. What is the most important point which has been given in Thiele's operative gynecology is this terminology itself has become less relevant clinically, as with the introduction of mid-urethral sling surgery as a surgical treatment of SUI, what has been seen is mid-urethral sling surgery is equally effective in SUI of any underlying pathophysiology. That means whenever we are evaluating a patient, we need not be differentiating between whether there is a urethral hypermobility, whether there is an open bladder neck, how much is the urethral closure pressure. All these points we need not be differentiating from the other cases, because mid-urethral sling surgery is equally effective even in presence of severe stress urinary incontinence because of any of the underlying pathophysiology. And so with introduction of mid-urethral sling surgery, in short, this relevance of this intrinsic sphincter deficiency terminology has diminished in modern gynecology. Now, this is a classification of SUI which was introduced by Blavas and Olson in 1988. And why I have included this is even Thiele's operative gynecology talks about type 3. So we need to know what is type 1, what is type 2, and what is type 3 by this classification. Now, this classification is based on only 2 parameters. One is relationship of bladder base with respect to inferior margin of pubic symphysis, which is short form which is used is IMPS. IMPS is inferior margin of pubic symphysis. Relationship of bladder base with IMPS at rest and on straining. That is one parameter. Second parameter is what is the status of bladder neck BN, whether it is open or closed at rest. So these are the 2 parameters on the basis of which we have, or this Blavas and Olson have divided SUI in three types, type 1, type 2, and type 3, based on these two parameters. So type 1 is there is a normal position. So position of bladder is based with respect to IMPS is normal in type 1, and bladder neck is closed at rest. What is abnormal here is on straining position, there is a bladder base position is normal at rest, but after straining there is a descent of bladder base, but the descent is less than 2 centimeters, and there is a with this descent what is seen is there is a leak on straining. So if you do the testing in a normal position as well as you repeat testing when the patient is straining, and with straining if there is a descent of this bladder base, and with that if there is a involuntary leakage of urine but the descent is less than 2 centimeters, then it is type 1. Type 2 is when the descent is greater than or equal to 2 centimeters, which is further divided into 2A and 2B. 2A is again at rest, normal position, and bladder neck is closed. But with straining, there will be rotational descent, which is seen with cystourethrosis. So there is a descent of this urethra, but it is rotational descent, which is usually seen in pelvic organ prolapse. And with POP, if there is stress urinary incontinence, it is type 2A. Type 2B is when at rest only, bladder base is abnormally low. It will be at a lower level with respect to inferior margin of pubic symphysis at rest. Then it is 2B. And the descent will be greater than or equal to 2 centimeters. Type 3 is when bladder neck is open at rest, but the position of the bladder base is normal at rest, as well as on straining also position remains normal. What is seen is bladder neck is open even at rest, or in other words, what we have seen is as a internal sphincter deficiency, that is type 3. So diagrammatically, again, to see this Blava's classification for postgraduate students, I think you should know this classification, though it is not given in some of the textbooks, because that clarifies the pathophysiology to a greater extent. So what is there in type 1 is there is a descent, but descent is less than 2 centimeters. So this is a normal position where the bladder base is at the above the inferior margin of pubic symphysis. This is pubic symphysis, this is inferior margin of pubic symphysis, and bladder base is normally at rest is above the level of inferior margin of pubic symphysis. But with straining, there is a downward shift of this bladder base. So descent of the bladder base is there with straining, but the descent is less than 2 centimeters. And with this descent, there is a leak, involuntary passage of urine. Then it is a type 1 SUI. What is type 2 is the descent is greater than or equal to 2 centimeters. Where if it is associated with pelvic organ prolapse with a rotational descent, it is 2A. And 2B is when there is absence of pelvic organ prolapse, but there is a significant descent which is seen even at rest. Then it is 2B. And with that descent, there is a leakage of or there is a incontinence with raised intra-abdominal pressure. Type 3 is, as you can see, bladder base is absolutely in a normal position with respect to inferior margin of pubic symphysis at rest as well as after straining. But what is seen at rest is an open bladder neck. Then it becomes type 3, or what we have described is it as an internal sphincter deficiency. Now, after pathophysiology, coming to the risk factors for stress urinary incontinence, if you see age is a risk factor, and especially the SUI peaks in 5th decade. Whereas, it is said that after vaginal delivery, usually, if SUI is because of the weakened supports, it manifests usually 2 decades after the delivery, and that is how it is used. Majority of the cases or the peak of this, if you see 100 cases, Majority will be in the 5th decade whenever they present for the first time with SUI. As a woman becomes old after 50, in 60s or 70s, it is less likely that SUI will present for the first time. What is more common in that this elderly population is a mixed type of incontinence. So you must understand is sometimes patient may approach a doctor in 70s with SUI, but she has SUI since 1 or 2 decades in that case. So onset of SUI maximally seen in 5th decade. Racial differentiation is there, that SUI is more common in whites, whereas urgency incontinence is more common in blacks. During pregnancy, SUI is more common. With increasing parity, SUI prevalence increases. Obesity is a risk factor for SUI, so that weight reduction is associated with reduction in the severity of SUI. Diabetes mellitus is a risk factor, and control of diabetes also helps in reduction in severity of SUI. Smoking is a risk factor. Pelvic organ prolapse itself is a risk factor, especially anterior compartment defect. Surgery for POP is a risk factor because SUI, which is occult before surgery, sometimes becomes overt after anterior colporrhaphy. And hysterectomy itself is said to be a risk factor because it sometimes leads to weakening of the supports of anterior vaginal wall, leading to SUI. Now, for diagnosis of SUI, we always, whenever we get a theory question, or even if you are asked in practical examination about any disease, how do you diagnose? Always start with the history, then come to the examination, and then go to the investigation. Never jump to the investigations if you are asked about a diagnosis of any clinical entity. So in SUI also, we start with history taking to diagnose a case. What needs to be ascertained carefully when we take the history is which activity leads to incontinence, so that it indirectly tells us about the severity of SUI. Coughing, sneezing, or laughing, or sometimes with the increasing severity, there can be coital incontinence also, or there can be in severe cases of SUI, incontinence can be there even with a change in position, or there can be nocturnal incontinence, that incontinence which is specially observed by the patient in a deep sleep. So all these we can differentiate or we can determine the severity on the basis of careful history taking. Then we need to again on history only see whether there is a SUI alone or whether it is in combination with urgency. And whenever it is in combination with urgency, the history can be confusing and it might take more time. But though it can be time consuming, it will be rewarding because history itself points to the diagnosis in almost 50% of the cases. If it is a combined type of incontinence, that means patient has incontinence with raised intra-abdominal pressure as well as she has a feeling of urgency, then in that case we need to ascertain which is predominant. So we can ascertain that by asking the patient to keep a voiding diary for 48 hours. In the voiding diary, what she has to mention is she has to keep a record of whatever liquid intake she is taking. She has to take a record of number of times she has passed urine or about the voiding, as well as she has to record the timing when she has incontinence and the activity which was preceding the incontinence, or whether incontinence was preceded or associated with urgency. So in all these 4 columns, this voiding diary to be maintained by patient for 2 to 3 days, which helps us in a great manner to decide in a case of combined incontinence whether stress urinary incontinence is predominant or urgency incontinence is predominant. Then we need to know by history, is it urinary retention with incontinence? so that patient can say that there is a difficulty in passage of urine and she would fail to pass urine for say 12 hours or 24 hours, and then now it is followed by involuntary passage of urine. That will give us an idea about the possibility of having a urinary retention with incontinence. Then most important is whether this it is affecting her quality of life and how it is affecting. Whether she has, because of this incontinence, social restrictions are there, or whether she has anxiety or depression because of that. That will all come under whether the SUI is affecting her quality of life or not. That will mainly decide whether to proceed with a surgical correction or not. Because if it is not affecting quality of life, conservative management will be sufficient for a patient. Then any medication history, some antipsychotic drugs or some medications can aggravate this incontinence. And whatever drugs patient is taking, we need to go through that also. Especially in India, we have to see whether she is taking any Ayurvedic or homeopathy medication also, which might be aggravating the symptoms. And whether there is any history of prior surgery for SUI itself or any other pelvic surgery or surgery for pelvic organ prolapse. In the examination to diagnose SUI, per abdominal examination is important along with the general examination. Per abdominal to see for mass, presence of ascites or full bladder. Then local examination to see whether there are any skin changes because of the incontinence over the vulva. Then we need to do cup test, which can be done on adequately, comfortably full bladder, or if patient, you are examining the patient on empty bladder, then also we can try and see whether the cup test is positive. If it is negative on empty bladder, then we need to re-examine the patient with a full bladder. Then we need to see whether there is associated pelvic organ prolapse, especially apical and anterior compartment defects. That we need to focus on. If patient has got severe constipation, that can aggravate SUI, or whether there are any pelvic masses which are leading to raised abdominal pressure. Then we need to rule out urethral diverticulum. Now, urethral diverticulum, we can suspect if there is a redness around the urethral orifice or swelling around the urethral orifice, and in that case, cystoscopy is the investigation. Though it is rare, it will help us to diagnose urethral diverticulum. Now, we used to do as postgraduates this Boney's test, and it was a favorite question asked in the practical examination also, that how you perform do the Boney's test or Marshall-Boney test. What is done in Boney's test is, if there is a stress test or cough test which is positive, that means you ask the patient to strain and you see involuntary passage of urine, that indicates that there is a presence of demonstration of SUI. SUI is demonstrable, or it is also sign of SUI is also positive. In these cases, whenever there is a positive stress test, what you do is either with the instrument or with fingers, you slightly lift up the uretrovesical junction. After lifting the uretrovesical junction, if there is no leak, that is suggestive of urethral hypermobility or a descent of bladder base as a underlying cause of stress urinary incontinence, and it is indicative that usually in these cases surgical outcome will be good. For that, this Boney's test was performed. Now, in modern gynecology, if you see all the textbooks and guidelines, this Boney's or Marshall-Boney's test is not recommended at present because of its poor reliability. It is less reliable. Its sensitivity, specificity, both are too low, and that is why it is not even included in the latest edition of Tilland's operative gynecology in the physical examination. I have included it here because you should know, if you are asked in practical examination, some of the examiners might still be asking about it, and that is why I have included it. Now, another test which is a part of physical examination is cotton swab test or Q-tip test for diagnosis of SUI. This is another controversial area in the physical examination for diagnosis of SUI. Now this cotton swab test, it assesses urethral mobility, or it helps us to diagnose urethral hypermobility. Hypermobility is when the urethra is in a this bladder base or uretrovesical junction, as there is a descent of it, and so that the urethral mobility is more than normal. That is why it is called as urethral hypermobility. What is done is lubricated sterile cotton swab is used, and usually lignocaine is also applied over the cotton swab at the time of insertion, and then it is inserted for 2 to 4 centimeters in the urethra till you feel the resistance. Wherever we feel the resistance, we know that we are at the uretrovesical junction. Goniometer is used. So we need a goniometer because we need to measure exactly in degrees how much is the movement of this cotton swab on straining. And that is why the instrument which we need is a goniometer, by which we can measure the shift of this cotton swab in degrees. How many degrees is the shift? If on straining, if the movement of the cotton swab in upward direction is greater than 30 degrees, it is indicative of a urethral hypermobility. Now, disadvantages of this cotton swab test. Frankly speaking, I have not done this cotton swab test in any patient, and the main reason is it might cause significant discomfort. It is invasive. Whenever we introduce, though it is a sterile cotton swab, there is a possibility of urinary tract infection because of this test. And there are high false negatives. The meaning of this sentence is false negatives is when the test is positive means there is a presence of urethral hypermobility, or there is a movement of this cotton swab in upward direction which is greater than 30 degrees. Negative test is when the movement is less than 30 degrees. Then we say that the test is negative. Now, if test is negative, that means there is a urethral hypermobility is absent. But this is false in many cases. So even if the movement is less, there can still be urethral hypermobility. That is the meaning of this sentence, that it is associated with high false negatives. Its advantages, it is inexpensive, and you can do it in a OPD. It can do in a outpatient department also. Doesn't need any anesthesia, and this is the advantage. Positive test is suggestive of urethral hypermobility if straining leads to upward movement of this cotton swab by greater than 30 degrees. So this is how diagrammatically, this is pubic symphysis, this is bladder, and this is the cotton swab, and if it moves in upward direction with a movement of greater than 30 degrees, we say that it is a positive test. Positive test is suggestive of urethral hypermobility. In short, in this patient, because urethral hypermobility is there, success of mid-urethral sinks is high. That is why we want to know whether our surgical procedure will be beneficial for the patient or not. So if urethral hypermobility is present, mid-urethral sink surgery success is high, and to know that this test is being done. Now, because it leads to so much of discomfort, another way of doing is you introduce a catheter first, and by the side of catheter you introduce the wooden end of this cotton swab, which is usually leading to less discomfort, but it will be less reliable as compared to the direct introduction of the cotton swab without catheterization. Now, so many textbooks are giving it as a Q-tip test. So, what is Q-tip? Or so many articles also, if you read on SUI, you will find Q-tip test, and you will be confused what is the difference between cotton swab test and Q-tip test. Now, Q-tip is nothing but a market name of the cotton swab, that you remember. So Q-tip test is same as cotton swab test, but Q-tip is a market preparation which is a sturdy plastic or paper stick with cotton swabs which are present at both the ends. That is called as Q-tip. It is a specific commercial product of a company. And so many times it is Q-tip test is used instead of cotton swab test, but any cotton swab can be used for testing this, and that is why the terminology which is correct is cotton swab test and not the Q-tip test. Positive test predicts good surgical outcome with the good surgical success of mid-urethral sling surgeries. Failure rate of the surgery doubles with negative test. That means if it is a negative test, it is indicative of a rigid urethra. And with rigid urethra, the failure, it is not that in every case there will be failure, but failure rate is double with a negative test as compared to positive test. Now, though it doubles, still success rate is quite high in spite of there being a rigid urethra or in spite of absence of urethral hypermobility. And that is the reason this test is not recommended by American Urology Association, NICE, that is UK guideline, European guideline or French guideline. All these guidelines have stopped recommending cotton swab test as a part and parcel of physical examination for the diagnosis of stress urinary incontinence. Transperineal ultrasonography is under research at present as an alternative for the diagnosis of urethral hypermobility, where what is done is transperineally ultrasonography is being done. Probe of the ultrasound is kept over the perineum, and what is seen is where the bladder base is present at rest and whether there is a change in the position of bladder base with the descent, and how much is the change in position. Depending on that, urethral hypermobility is diagnosed. But at present, this investigation is under research and it is not a part of a routine evaluation of a case of stress urinary incontinence. Coming to the last part for the diagnosis of SUI, investigations, urine microscopy culture and sensitivity to be done, as any urinary tract infection aggravates urgency incontinence as well as stress urinary incontinence with an increase in frequency. Then most important is to see how much is the residual urine. This you can see by doing a simple ultrasonography, post-void ultrasonography, or catheterization can be done to ascertain how much is the residual urine. Up to 50 ml residual urine is usually considered as normal. Anytime residual urine is greater than 150 ml, it is considered as abnormal or suggestive of a voiding abnormality in a patient. That patient is not able to pass urine normally, and that is why there is a more of residual urine, and if it is significant, even it can be suggestive of this urinary retention also. Transperineal ultrasonography, as we have already seen, it is done to diagnose urethral hypermobility and it is at present under research. Voiding diary helps a lot. It is part and parcel of our history taking as well as an investigation tool also, where carefully patient has to document liquid intake in how much liquid she is taking and at what time of the day. Voiding according to the time of the day and night. Incontinence also she has to notice the timing of that, and such a record she has to keep for 2 days and bring it to us. That helps us in many ways to differentiate in a mixed incontinence, especially which one is predominant, whether it is stress or urgency. Complex urodynamic evaluation is usually not needed for conservative treatment. It is needed in selective cases of surgical management preoperatively. So even for surgical management, it is not needed as a routine. Only for a specific group of patients, we need to advise this complex urodynamic evaluation. Simple cystometry is also useful in some cases. Cystoscopy is not considered as a routine investigation. It is indicated only and only if lower urinary tract abnormalities such as diverticulum is suspected. Criteria for surgical correction of SUI without complex urodynamic study. Now, this is very important, that what is the criteria when we can proceed with surgical correction, and we don't need to go for a complex urodynamic study to diagnose SUI. If there is a clear history of stress urinary incontinence or SUI dominant mixed incontinence, then in that case there is no need to do the complex urodynamic study. Confusing symptoms are there, then it needs a detailed evaluation, as predominantly urgency incontinence will not improve with surgery. That is why we need to, if symptoms are confusing, then we have to proceed with this complex urodynamic study. Clear-cut symptoms, then of SUI, there is no need. If post-void residual urine is less than 150 ml, there is no need to go for complex urodynamic study. Greater than or equal to 150 ml is an indication to do complex urodynamic study. On examination, cough test or stress test is positive for SUI. So clear history and demonstration of SUI, that is the most diagnostic, and both are present, then there is no need to do complex urodynamic study. But if you are examining the patient with full bladder also, and still in a standing position also, and still you can't see the incontinence with the straining, then in that case we have to proceed with this complex urodynamic study. Positive cotton swab test is there, then there is no need to do complex urodynamic study. Rigid urethra, if it is a negative cotton swab test, rigid urethra is associated with increased failure rate. But remember that nowadays this recommendation has been taken away by most of the latest guidelines by American Urology Association 2023 guideline or NICE guideline 2019. They are not recommending use of this cotton swab test to decide whether to proceed with urodynamic study or not. Pelvic organ prolapse up to stage 2 is, if it is up to stage 2, there is no need to do complex urodynamic study. If it is more than that, greater than that, then we need to do the complete urodynamic study. If there is a previous history of surgery for SUI which has failed, then this is a specific indication to do complex urodynamic study. Patient has received any radical surgery, pelvic surgery or pelvic radiation, then it will be an indication to do the complex urodynamic study. And if patient has neurological disorder, then we have to go for that. Otherwise, there is no need in a straightforward, uncomplicated case of SUI. There is no need to do complex urodynamic study is the important take-home message. So this is the most important slide, I should say, in the today's presentation. If you are asked what are the indications to proceed with complex urodynamic study preoperatively in a patient of SUI, confusing history, residual urine greater than or equal to 150 ml, negative stress test for SUI, negative cotton swab test, pelvic organ prolapse greater than stage 2, previous history of SUI surgery, history of pelvic radiation or radical surgery, history of neurological disorder. These are the indications for, in other words, complicated SUI needs complex urodynamic study evaluation before we proceed with the surgery. Now, what is simple cystometry is catheterization is done after voiding to see how much is the residual urine. Then bladder is refilled in a retrograde manner with the help of gravity, by using gravity. And then what we have to notice, how much is when is the first sensation of bladder filling, at what we have to fill the bladder with around 60 ml every minute. And then whenever a patient says, we have to keep on inquiring and asking the patient. Whenever she says there is a first sensation of bladder filling, we have to note that. Urge to void for the first time, we have to note. Urge to void, if convenient, we have to note. And strong desire to void also we have to note. And we have to note the full bladder capacity. Then we have to remove the catheter and ask the patient to cough or strain. If passage of small quantity of urine is there, it is suggestive of SUI. But if there is a complete emptying, it is suggestive of detrusal instability. And for confirmation, it needs a complex multi-channel urodynamic study. So what is done in complex multi-channel urodynamic study? This is not included in our routine textbooks, but I have included so that our ideas have to be clear whenever we are referring a patient. We should know for what we are referring. So what is the use is a multi-lumen urodynamic catheter, which is inserted in bladder. Other catheter is inserted in either in the rectum or vagina, and this will be mainly to measure abdominal pressure. Transducers are attached to the catheters to measure pressure, and bladder is filled with pump whenever this testing is being done. 5 components are evaluated whenever this multi-channel urodynamic complex study is done. First is uroflowmetry. That means at what rate patient is passing urine, whether there is a voiding, abnormality or difficulty. So patient, first you take the patient for study with a full bladder, ask the patient to pass urine and measure the passage of the urine in ml per second. At the end of voiding, you also see for residual urine by doing the catheterization. Cystometry is the second component, where as we have seen in second previous slide in simple cystometry, same way bladder is filled with the help of pump, and we have to see when is the first sensation of filling, first sensation for voiding, first sensation of voiding if convenient, and first sensation of strong sensation for voiding, and total bladder capacity. Then pressure flow study is how much is the pressure by detrusal muscle and how much is the pressure in urethra during micturition. That is to be that is measured under this. Then urethral pressure profile, urethral pressure and how much is the urethral, what is the urethral competence also, whether urethra is competent or incompetent. Then electromyography of the pelvic floor muscle activity is done mainly to assess the supports of the urethra. So these are the 5 components which are assessed. What the parameters which are measured are how much is the vesical pressure or bladder pressure, how much is the maximum urethral closure pressure, how much is the abdominal leak point pressure, how is the detrusor muscle activity during incontinence, whether detrusor muscle activity is seen on the graphically or not, how much is the residual urine volume, and how is the tone of pelvic floor. All these parameters are assessed, and ultimately what it helps us is to know, especially in a confusing history and examination findings, we are able to confirm our diagnosis, whether it is a case of stress urinary incontinence, urgency incontinence, or a mixed incontinence with dominance of either of these two. So with the incontinence, SUI is most common, especially in the 5th decade. Elderly population, what is becoming more common is a mix. Mixed incontinence can be with the dominant element of either SUI or urgency, and third is a urgency incontinence. In the pathogenesis, in short, there are only main 2 components, urethral hypermobility and intrinsic sphincter deficiency. Urethral hypermobility, there is a descent of the urethra below true pelvis. So here, as diagrammatically you can see, there is a raised intra-abdominal pressure. Normally, it is acting on bladder base also, this raised intra-abdominal pressure, and it is closing the uretrovesical junction, and that is why with raised intra-abdominal pressure, patient is remaining continent. Here, what is happening? There is a descent of the bladder base, and raised intra-abdominal pressure is not getting transmitted here. It is only acting on the upper part of the bladder, and that is the reason this uretrovesical junction opens and patient has leak. Internal sphincter deficiency is at rest only. There is no descent of bladder base, but at rest only bladder neck is remaining open, and that is why whenever there is a raised intra-abdominal pressure, patient will have leakage. In majority of the cases, what we need to remember, what has been found in modern gynecology with the continued research is, in a given patient, Usually there is a component of both urethral hypermobility as well as internal sphincter deficiency is the most important point we need to remember. Suspected SUI, you take detailed histories and you can take help of voiding diary, and we need to assess whether it is affecting quality of life or not. That is most important. On examination, we need to examine for anterior and umbilical compartment defect or pelvic organ prolapse. Stress test, we need to, if we get positive stress test or cuff test, that helps a lot in the clear-cut diagnosis. Cotton swab test is at present, it is controversial or it is not recommended presently by most of the current guidelines, though it has been mentioned as a part and parcel of physical examination in Tilland's operative gynecology. But Novak says that at present it is not being recommended by American Urology Association. In the investigations, residual urine we need to see in each and every case of suspected SUI. That is most important and can easily be done non-invasively by doing ultrasonography. Or you are doing catheterization for some reason, then you ask the patient to pass urine and come. Then post-void you do catheterization and see how much is the residual urine. But catheterization is a relatively invasive way, and that is why ultrasonography will be better. Urine microscopy culture sensitivity should always be done in each and every case of suspected SUI. The rest of the investigations are not obligatory in each and every case. In majority of uncomplicated SUI, there is no need. In selective complicated cases only, we need to do simple cystometry or complex multi-channel urodynamic study or cystoscopy. NICE guideline 2019 helps us a lot to deal with the patients. If history is suggestive of SUI, and if on examination on stress test or cuff test, we can see the escape of the urine, that means it is an uncomplicated or clear case of SUI. So in uncomplicated SUI, for primary surgery, whenever patient is not for repeat surgery, but she is for the surgery for the first time. For primary surgery, there is no need to do the Bonis test. It does not help us to assess the success rate of surgery. No need of doing even a cotton swab test has been clearly written in this NICE guideline 2019 that cotton swab test is no more being advocated as for an evaluation of a case of suspected SUI. No need of cystoscopy, no need of urodynamic tests for a uncomplicated SUI for primary surgery, and no need of X-ray, MRI or CT scan. Ultrasonography also only indicated for assessment of residual urine. Thank you so much. These are the references. Tilland's operative gynecology, Barrett Novak's gynecology, NICE guideline 2019, American Urology Association guideline 2023, and this reference I have specially given because it has given clearly about the pathophysiology by British Association of Urological Surgeons. Thank you once again.